My name is Shahid. I'm a final year medical student in Australia. Having studied medicine here, I've had to become really good at clinical OSCEs as we have these big OSCE exams at the end of every single year. I just finished my final OSCE exam a couple of months ago and I did really well at it. Having thought a lot about OSCEs in the last few years, I've realized more than just knowledge, it's about the approach, the structure and the game plan that you have when you walk into a station. No matter what the STEM or the scenario is. Today, we'll go through that structure, through every single second of what you should be doing during an OSCE station. I hope you enjoy it. Please do subscribe on this channel.
Basically, if you think of it as a table, there's certain ways I'd like to divide the OSCE. So the first one being the 2 minutes outside when you read kind of station. And then the next bit would be, it's not let me type. Yep, so 2 minutes STEM reading. So there's certain things we have to do around then. And then there's the introduction when we go in. So I think of introduction as something from 30 seconds to about a minute. And then obviously if it's a history or a physical exam, things would be different. But if we take both as an option, the first kind of, say, 2-3 minutes if we are doing a history is the history presenting complaint, and then the main task that you're asked to do in that station. So think of history presenting complaint. And this is a really important point. I think one of the mistakes we kind of do in OSCEs is when we think of an OSCE from a history or a sample history point of view, we think of the whole thing together. And I really like thinking of history presenting complaint like a complete different section than the overall history. And then we'll come back and talk a bit about it. And then after that history presenting complaint, there's the kind of rest of the history that you have to kind of finish off. So that's one way to kind of look at it. If it's a physical exam, you have your 2 minute STEM, you have your introduction, 30 seconds to a minute. And then again, you kind of have a history presenting section, which is something like if it's a small bowel obstruction kind of presentation, and they're not telling you what exactly they want you to do, but they're just saying someone presented with abdominal pain and vomiting. So how do you go about that? So then the way I think of it is like, yes, there is the whole gastrointestinal examination that I can do, starting off with hands and looking at the nails and doing commenting on the nails and clubbing and IV sites and all that kind of stuff. But then there's also the abdomen, which is like the main kind of focus. So that's like the history presenting complaint or the focused examination kind of approach. And then you have the rest of the examination, whatever that might entail. And this is again really important. So for example, if the STEM is very heavy on like a vascular examination or like a lower limb diabetic examination, and then you go and in a typical kind of vascular exam, you would want to do all the blood vessels in the body, starting from your hands, taking your radial delay, your elbow, and everything else. But then if it's a very particular presentation of a lower limb vascular exam, and then you're spending more than half of the station just focusing on the upper body, then obviously that's not a good sign, and you don't get the benefit of the doubt, because after half the station time has passed, you might come to the lower limb and notice that they have an ulcer that you need to comment on or you need to examine properly. So again, it doesn't look nice. And worst cases, you spend all this time checking vessels in your upper body and then your heart, and then you don't even get to the leg till the rest of the time. Okay, so now let's go back and talk about the specific sections. So the 2 minute STEM, what do we kind of do in that bit? Everyone has different approaches. Well, the best thing would be is like you take some advice and you go and try out in your practice OSCEs, and then you see what works for you. This is what I do. So when I go in, I quickly read something first, and most of the time, if you read something, not much goes in and it's long and it's hard to take in a lot because you're nervous. then what I do is I read again and I try to read the last question, like what is it they actually want me to do? So look at the task, like is it a history? Is it an exam? Is it a bit of both? Is it a communications? It's really important to kind of get the task clear in your head. Obviously, sometimes there's a bit ambiguity what they want you to do, but it's very important to kind of very clearly get your task in your head. The other thing that I've learned to do, just because as the OSCE is becoming harder, is that double check. So often, you know, on the first glance, it looks like, yes, it's a examination station, but then there's like a sneaky word where they're saying history. So what I always try to do is first read the stem quickly and then read it again. And when I'm reading a second time, the goal is to figure out if it's a history or a physical exam kind of station. So figuring that out on, so just I'm just gonna write this here. So you read, no, I don't know about that. So 2 minutes STEM. Oh, come on, 2 minutes STEM. And then you read it first, and then the second time when you read it, you find the task, that's your goal. And the third time when you read it, the goal is to pick up the details. What I mean by that is if it's the story of a farmer who is in the mid-50s and they've come to see you in the clinic today, that kind of story makes me think of, you know, depression or a cardiovascular kind of issue, because that's demographic. So they're becoming very sneaky with these OSCEs, and they try to give you these hints on, you know, there's the story of a, you know, 22-year-old with a discharge. So it kind of makes you think like an STI. So you pick up those kind of small details. And the third thing that you do, the next thing that you do is think of a couple of diagnoses. So not, I personally don't like to focus a lot on this, just because if you get really stuck on a diagnosis, you go in and you just focus on that, you become tunnel vision. So some people like to do that a lot. They just focus on their diagnosis, but I just try to think of one or two. And the final thing I like to do is figure out what I'm going to do. This is very like simple and crude, but that is like the last 30 seconds of my kind of 2 minute STEM outside. I know it's a lot of different things. Obviously, this is generalizing the whole kind of OSCEs, depending on if it's a physical exam, if it's a history, if it's a communication, things will change. A lot of the time, if it's like a communication, then you just spend your time thinking, you know, what you're going to talk about. But this is generally the comprehensive structure that I do. Most of them doesn't take time. So your reading doesn't take time. Finding what the task is, just one line. Small details, it's usually the first or second line, and then thinking what's going on. So the first kind of 1, 2, 3, 4 tasks that I've put there should take no longer than like 45 seconds or a minute. Like within a minute, you should be able to do all of this. Read, find what you need to do, figure out small details, think what's going on. And pretty much the second half. So I'm just gonna put this on a different line. So 2 minute. So 1 minute, you do all this. And then the second minute, you kind of figure out what I'm going to do. And I get really, really detailed here. Like I think when I'm gonna go in, I'm gonna say hello, I'm gonna do this. The first thing I'm gonna ask about is this. The second thing I'm gonna ask about is this. And then maybe later on, I figure some, what I think is it's unrealistic to think of like the whole history that you'd ask in we start the station in a minute. But what's most impactful is if you spend a couple of from that 1 minute, the first 30 seconds on what would be the first couple of questions or the first 5 questions that you ask, and the next 30 seconds thinking what are some important questions. What I mean by that is if it's a history of, say, someone with hepatitis, what I think about is the first 30 seconds, I think like, oh, when I'm going to go in, I'm going to ask about, you know, do you know you have hepatitis, or do you have any symptoms? I can say things like, you know, people with hepatitis experience things like, you know, jaundice, pale stools, dark urine, confusion. Is that something that you've been experiencing? Do you have any symptoms at all? Do you have any abdominal pain? If there is pain, do a Socrates. So basically, those are the first kind of 4 or 5 questions that I ask. But I'd also spend some time thinking, make sure you don't forget to ask about IV drug use. Make sure you don't forget to ask about alcohol, tattoos, travel. So what I mean by that is you got to figure out the first few minutes what you would do and the important thing. And the reason this is important is because when you go in, the first few minutes, you shouldn't look, so I'm going to talk about it in a second, but the first few minutes, you shouldn't look flustered. You shouldn't look like you're thinking what you're going to do. You should look like you know what you want to do. And the way you do that outside, you've already thought about the first 3 questions that you ask. Again, as I said, it's possible to think about all the questions that you'd ask, but it's okay to think about the first kind of 2 3 questions that you'd ask. And then you also think about what's important. And that comes over time. The other way I think of what's important is I often think like, you know, what is something I missed the last time I did this station? Or what is something I missed to ask the last time I practiced this OSCE? So a very typical example is if you're doing like an obs and gynae, I think about, oh, you know, the last time I did this station with a friend, I kind of forgot about asking about pap smear or pregnancy. So I'm not going to forget it this time. Or another very typical example, anything mental health, anything substance, anything alcohol. The last time I did this station, I forgot to ask about suicidality, which is huge. Like you're going to fail a station if you don't ask about that. So I remind myself, make sure you ask about that. So again, just summarizing, 2 minutes outside, you spend the first minute reading once, then you reread to find the task, then you reread to find small details, then you think of 1 or 2 diagnoses. Then the second minute, the first half, you spend, so first half is about the first 5 questions, and your second half is about the important questions. So we've done the 2 minutes, what we do outside, and now we knock and we go in. And this, like in my opinion, is the make or break of how your OSCE performance is. So I think it's just super important that you have like a powerful intro. And let's talk about how we can have such a powerful intro. First thing is some soft skills. So things like being loud and clear and confident. And this is something I think, again, it's a bit embarrassing. It's maybe not so helpful if you're thinking as a medical student, but really if you think about OSCE as a game, this is something very important, and I encourage all of you to practice it in front of like mirrors, in front of, you know, I used to do it in front of bed, so I live in a room by myself, and I usually just, you know, talk to a pillow and kind of practice it. So it's so important to have it loud and clear and be confident. And one of the ways you can do it is having a script that you're confident about. So I usually go and say, hi, my name is Shahid, I'm a 4th year medical student, and I'm here to do this examination. And it really depends on whatever your script is. It just has to be very loud and clear, and in your tone kind of show that, you know, I'm here to do what you've asked me to do. So when I was doing the emergency physician's exam yesterday, they were doing like a pediatric situation where someone came with a trauma, and a good example is someone coming in and saying, hi, I am your emergency consultant, and I just got a notification of a pediatric trauma. Let me tell you about it. Or a bad example is someone coming in and being like, oh, hi, my name is this. What's your names? I don't know if you guys have heard. There's a kid that's coming. Has the ambulance given you any info? It's like they're asking questions. You don't want to ask questions in the first kind of, you know, your first thing that comes out of your mouth shouldn't be a question. That doesn't show confidence, because the examiner's like, oh, you just come in, tell us a bit about you. So whatever that is doesn't matter, but you just have to be very loud and clear and confident as soon as you walk in. And I usually think, because it doesn't add so much to your mark, you should start talking as soon as you walk in. So that's the other kind of soft skill, small thing. Often people like knock, go, you usually have to give a sticker to the examiner. They go stand in the middle of the thing, wait, you know, for a good 30 seconds to go, and then start talking. You just wait 30 seconds. You would just quiet for so long, and you can really use that time. So, you know, even when you knock, go in, don't look at the examiner when you're giving the sticker. Give it with one hand. Usually what I do is before entering, I take the sticker and put it on my finger. So when I'm inside, I don't have to act clumsy. I just knock, go in, I give them the sticker, and then I start on my script. Again, please have a script. I gave you one example of my script. Another example of my script is usually, I have mentioned this before to the second years, I usually just look at the stem. This is the last thing I do before I walk in. So if it's someone like David Peters, the last thing I do is I look at their name, and then as soon as I go in, I say, Mr. Peters, is it all right if I call you David? David, my name is Shahid. I'm a fourth year, second year, first year medical student. I've been asked to come and see you today. I've been asked to come and talk to you today. Will that be all right? I know you guys get a lot of different recommendation about confidentiality, about consent, which is fine. I personally don't do it because it's not a critical fail for the marking schemes that I've seen it, but I wouldn't recommend kind of, following that blindly. If you personally feel it's important to kind of give a confidentiality spill, give a, no one's going to know about this, do it. It's more recommended obviously in like sensitive history stations, like a pap smear or a contraception kind of consent. If it's like a general back exam or general leg exam, like really the patient doesn't care if it's confidentiality safe or not. But again, if it's part of your script, just do it quick. You knock, go in, Mr. Peters, is it all right if I call you David? David, I've been asked to come and see you today. I just wanted to ensure that this is just between you and me. If at any time you don't feel safe, you let me know. Whatever it is. Have your script, write it down, practice it, see what works, and just be loud, clear, loud and clear and confident when you walk in. And I think some boys have this naturally. Girls might have to work a bit more. Again, I'm sorry to kind of point out those soft skills, but it does make difference. The best tip that I've always got is when you walk in, think of yourself as a middle-aged, good-looking white man, because usually most of them are big, they're loud, they're clear, and they're confident. That's what you have to do. And more important as a girl, like you just have to project your voice. Like, if they don't hear your name, if they don't hear you properly, it's hard. So just practice that. Like, hi, I am this, that. So soft skills, important. I think I've spoken about enough about that. And then let's have let's have a script. So whatever your script is, it can include checking patient details, it can be confidentiality, it can be telling them what you're doing, what you are about to do. It could be taking consent, etc. If it's a physical examination, usually sometimes it gets a bit tricky where what words you use. So for example, saying like, I have been asked to do a cardiovascular examination, and then some people argue a lot about if you should use jargons, like I've been asked to do a gastrointestinal examination, I've been asked to do a genitourinary examination, etc. People do it differently. There's obviously a recommendation on don't do a lot of jargons, but my personal preference so I just a question by Rohit. So you don't want to be too conversational at the start, is that right? Exactly. So 100%. Don't even ask questions. The way I'd interpret your question about conversation is if you think like asking, how are you? How's it going? Absolute no. Please don't do it. Please don't do it. Please don't do it. Like, do not ask, how are you? Do not ask, how is it going? Do not ask like, the only kind of time you can ask that kind of question, which sometimes independently, is if you're doing history and it's a very general history and you say, what brings you in today? Even that, I usually like to, give a, like a signpost. I say, I've read that you've been having headaches. What brings you in today? Giving that statement just makes them feel a bit more online, like, they're on topic. So that's the answer to your question, Rohit, that, don't be too conversational, just give information, because that's actually, it's hard to understand, but that's a way to show confidence. If you're going in, I'm going to go on a slight tangent about psychology. Like if you go in and you ask questions in your conversation, like psychology-wise, it just shows that you're a bit scared, you're a bit nervous. But if you go in and you show authority, you're saying things like, I have been asked to come and do this, and this is what I'm going to do, just shows a bit more control. So do that. Going back to the script for examination, as I was saying, there's some difference in opinion. If you should say cardiovascular, if you just say, I'm going to examine your heart. My personal preference is to say the medical word and then explain it, because I feel like that way you get tick from the examiner, because some examiners don't like it when you say, I'm going to examine your heart, because not really. You're going to do a cardiovascular examination. There's, you know, your vessels involved, and, you know, lungs involved. There's so many things involved. It's actually not just heart. So the way I like to do it, I say I've been asked to do a cardiovascular examination, which would include feeling your pulses. So this is, again, depending on what you're comfortable with, listening to your heart, checking your legs, etc. So this is my preference, saying I'm here to talk about this, which is the medical word, and this is what it means. So you kind of explain whatever that script is, just have it clear. Okay. So now I'm going to move on to history of presenting complaints. So this is the history on the left side and the examination on the right side. Okay, let's talk about the history. Again, I just really want you guys to think of every OSCE station as two parts. There's the history of presenting complaint, and then there's the rest of the history. So I'm going to break that out. Yep. Big part of OSCE, and helps to think of it separately. Okay. And the biggest thing with this is structure. So I'm going to write in a big thing. Okay. Structure. There's reasons for it. The first thing is, and like, again, it's a good timely question, Rohit. You were asking about conversation. So oftentimes, if you catch yourself, you will see that you get into conversations when you actually don't know what to ask next. If you know what to ask next, then you're less likely to go into conversation, because your head is buzzing with what I need to do. And it goes back to the first 2 minutes that I said. That's why the first 2 minutes is so important. Like, as you said, as you can see, I talked about what I'm going to do. That is just so important. Like, it might seem simple, but it's all about spelling it out in your brain, what I am going to do. So when you go in, so as you remember, the first 2 minutes I broke it down. In the last 30 seconds, you talk to yourself. The last 1 minute, you talk to yourself. What am I going to do? Going in, I'm going to do this, boom. And then your intro is done, and that's when you get into this kind of first 4 or 5 questions on that history of presenting complaint. And as much as it might seem obvious that, you know, I know how to take a cough history, I know how to take a pain history, etc., you should think of each symptom. So again, this is important, not as a diagnosis, not as lung cancer, not as COPD. You should think of each symptom, and you should think how I am going to ask my history presenting questions. So for example, if I've got pain, so that's usually simple, you do Socrates, right? So my site, onset, character, radiation, associated symptoms, exacerbation factor, Socrates. Okay, and then if I have cough, I would think of quantity, how it looks, if there's blood, if it's dry, if it's pain, etc. Frequency, how often they're coughing, exactly. If there's frequency, if there's a urine kind of problem, then you ask again. Frequency, volume, color, blood, etc. Okay. So again, this is a major part. Like I'm telling you, if you do your history of presenting properly, you will pass an OSCE station. If you don't do your history of presenting complaint properly, you will fail an OSCE station. And the best way to understand this is if you look at your marking schemes. Majority of the marking scheme is on history of presenting complaint. So if you think about it, if you look at a marking scheme, the introduction, consent, confidentiality, everything is like a small box on top. Your past history, family history, medications, allergies is like a small box on the bottom. what's the chunk in the middle? History presenting complaint. And I can tell you, after having examined like people doing OSCEs and stuff, that's where the money is. Like, even if you don't do consent, even like, you know, you give the benefit of the doubt, like who cares? But in the middle bit, if someone's forgotten to ask about blood and cough, if someone's forgotten to ask about how bad the pain is, if someone has forgotten to ask about volume and frequency of urine, I don't want them, I'm usually a very generous marker, but I don't want them to pass. Like, if you don't ask about blood in urine, blood in cough, like that's a big miss. So it's so important to have your money on the history presenting complaint. So how do you do it? So I've talked about why it's important and how do you do it, and the answer is structure. Now there's a few ways to go about structure. I personally like acronyms a lot. So Socrates is my, like, you know, I'm massively a big fan of Socrates, which is usually an acceptable one. So I'm hoping a lot of them would know. There's a few acceptable acronyms and there's a few that you have to make up. So for like the urine one, I remember this one that I studied while exams. It's kind of forgotten me, so I'm going to Google it. I think it was UNIS 2, but I'm just going to Google it. Urine questions. And I think it stood for U for urgency, N for nocturia, I for incontinence, S for stream. Yeah, that's all I can remember. But I've just Googled it, so we'll see if we can find it. I think I saw it somewhere and I didn't make it up. Looks like I made it up. So I don't have it here, but I think, yeah, those are the big ones, like urgency, nocturia. Oh yes, I figured out. So UNIS 2. I'll just write this down. So you've got urgency, nocturia, incontinence. What else do we have? S for stream, T for terminal dribbling. Dribbling. I can't remember the others, but I think E was like, somehow I related to intake, like how much they were drinking. And then I think W was weight loss or something. If I find it, I'll send it to you. But the point is that you need to have some form of structure. Either you have a mnemonic where you think of that mnemonic whenever you go in, or you write down. So the cough one, it's a bit hard to kind of come up with a mnemonic. I remember making up something like, you know, quantity, color, like Q, 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 C, C, C. That's not the point. And I'm not saying go and memorize, not learn mnemonics. The point is, whenever you think of a symptom, you have to think of like 4 or 5 questions, boom, boom, you ask. And then the good thing is you have to go and practice. And over time, when you practice, you will figure out which questions you like asking, which questions you don't like asking, which questions you easily forget. So this is like a big mystery in OSCE. Oftentimes, certain kind of people forget certain type of questions. I don't know why, but I think it's got something to do with making these brain connections. So hopefully, if you've taken nothing from this class, you've taken the fact that blood is important. So the next time you do a urinary or a cough or some sort of station, it'll somehow make this neuronal connection that Shahid was talking about blood. So it's important to talk about blood. Just like that, if you've practiced enough and enough people have told you, oh, you forgot to ask blood, you forgot to ask this, it'll kind of stick. So the thing is, as long as you have those main ones, it'll come. Like, you know, the UNIS 2 example. In an OSCE, I don't think I'm going to remember every single one. But you know what? It doesn't matter. Even if I forget urgency and I remember nocturia incontinence, I've, you know, done pretty well. Even if I just remember terminal dribbling, sometimes that'll make me think, oh, I didn't ask about the stream, like the flow, and that's important in like a prostate kind of situation. What I'm saying is that if you have some sort of structure, then your brain will kind of, from some place, try to bring a connection and make a reminder. The problem is if you don't have any structure, if you don't have nothing to start from, then your brain uses all its power to kind of think. It's almost like a car. Like if it's in motion, it's easier to push it. But if it's stopped, it's really hard to get it started. Our brain's like that. If I have no questions about cough, my brain just goes into this fluster mode where I'm thinking, oh my God, like what question to ask? But if I've asked already about like quantity, volume, then I think, oh, you know, I should ask about blood. I should ask this. So you have to have something. Some ones are obviously very hard to have mnemonics, and I recommend not having them. So for example, travel, like a fever in a return traveler is really hard. General fatigue is really hard. So in those ones, I kind of think about like practical questions, like what are the questions I'm going to ask? Like, duration. Have you had anything like this before? Can you tell me more about what you mean by tired? Like, have you lost weight? So the way to go about this is like studying them. So I don't know, maybe next class I won't pull it up now, but I've written down like these 5, 6, 7 questions for these common kind of symptoms. So it doesn't matter how long you have in your exam, I really recommend every day take a symptom and think about 4 or 5 questions. Like when you're riding a train, when you're going somewhere, when you're walking somewhere, just think about, if I had my case tomorrow, what could it be? It'll be a symptom. Someone presented with pain, someone presented post-fall, someone presented with unconsciousness, someone presented with dizziness. So like, dizziness is a great example. I'm just walking and thinking, okay, someone presented with dizziness. What would I ask? Now, if I hadn't studied it, then my brain would go be like, oh, what's this dizziness for? Like, is it hypoglycemia? Is it stroke? This. You will go into this, mode where you're thinking about diagnosis. You think you're a doctor and you will stuff it up. So don't think of yourself as a doctor. Think of yourself as a medical student getting through these exams, which are really hard. So the way my brain works in an OSCE mode, when I think about dizziness, is not about what diagnosis. I think about, okay, dizziness, before, during, after. So tell me before, what were you doing? Were you sitting and standing up? Okay, this could be postural hypertension. So this is my brain thinking. Okay, during, what happened? Did you fall? Did someone see you? Was there a seizure? So when I get answers to those questions, then I think about diagnosis. It's a bit of a hard point to explain, but I'm just going to repeat again. When you hear OSCE STEM, don't try to diagnose it. Try to think what question I'm going to ask, which is going to rule in or rule out a diagnosis. So just example like that. Don't think about dizziness could be from postural hypertension. Think dizziness, I'm going to ask about before. Were you sitting down and then you stood up and you got dizzy? Okay, now it is postural hypertension. So don't skip that step. It's like math, you're doing calculus, work out the steps and don't just be a dick and write the answer. Work out the steps, and that's what your brain is going to think. And the reason you need to work out the steps is that's where your marks are. If you look at the marking scheme, it's not about finding postural hypertension. It's about, did the person ask what happened before? Did the person explicitly ask what they were doing? Did the person ask, did they have a fall? Did they have any brain bleed? Did they have any seizures? After that, after the dizziness, was there any confusion? I hope I made my point clear, but it's all about what question you're going to ask, either through a mnemonic or through literal questions that you list down. Okay. Some other things with history presenting complaint, quickly I will, this is becoming really small, but quickly I will put down our focused systems review. I think is very important. So, it gives you a lot of marks. So just at the end, I usually signpost this. So I say, thank you so much for answering those questions. I just had some quick questions about your general health. Have you lost any weight? Did you have any fever, any rashes? Again, make a script in your head, whatever you are. Yeah, I cannot emphasize this enough. Please, structure. Like my brain is just buzzing with different structures. I'm going to write 2 more examples here. So for obs and gynae, I told this to my second year friends. I don't know if you guys remember, but if you do, you can put it on the comments. The obs and gynae structure that I follow is called MOSG, so which stands for menstruation, obstetrics, sexual, and gynecological. Like, this is literally the difference between me having a good, easy women's health station and a tough women's health station. Because it's easy, because when I go in, I think, boom, I'm going to ask about, menstruation. When did you start having periods? How regular are your periods? How many days do you bleed? Do you ever have painful bleeding, excessive bleeding? Okay, obstetrics, were you ever pregnant? Any miscarriages? Is there a chance you could be pregnant now? Sexual, have you had any STIs? Do you have a regular partner? How many partners in the last 6 months? Gynecologies, any discharge, any rashes, any pain? Sorry, I'm going quickly, but I just want you to show, like, I'm not even thinking. It's just my memory, like from memory, remember, like this is my first 2 minutes of a women's health station. And if I didn't have that, then I'd be going, oh, what do I ask? What should I ask about menstruation, etc. Another one is for your mental health. Yes, and it's sleep, interest, guilt, energy, concentration, appetite, psychomotor retardation, and suicidality. Yes. Okay. So the other point that I'd like to make about mnemonics is it's important to remember mnemonics, as I said, but it's also important to practice them and modify them to how it works for you. So an example being, I love Socrates, but I don't like the order. When I usually go in for a pain, I say, where's the pain? So I take the light. When did it start? Onset. Can you describe what it's like? Character. Is it moving anywhere? Radiation. The associated symptoms one, I feel like just doesn't flow because Socrates after RSA doesn't flow. So I skip A in my head. Then I go to timing. Is it always there? Anything makes it worse or better? Severity. How bad is it? 10. And then I do associated symptoms. Is there anything else happening? Just flows better. That's why practicing is important and working hard is important, because not only you have this mnemonics, you have to trial and test this mnemonic. You have to modify this mnemonic. You have to edit this mnemonic. When you go to the exam, that should not be the first time you're trialing the mnemonic. When you go to the exam, that should be the 100th time that you're trialing the mnemonic. And by that time, you've figured out that you've got the order right. It flows when you talk, just makes sense. So the point is modify and practice the mnemonic as it suits you. So everyone's different, but you have to be comfortable when you kind of say it. Okay. Focus today, like I'm not talking much on examination. Maybe I'll do another session just focusing on examination. But again, first examination, everyone has different opinions. Usually, if it's a gastro thing, I just in outside, I kind of figure out what's really important, and then I go in and I quickly go through everything else, and then I focus on that. If it's a like abdominal pain, I do look at the hand, I do look at the face, but I'm just very conscious of doing it quickly, and then I go into the abdomen because I know that's where the marks are. Another example is like a back and hip exam or back and lower leg exam. So you just from the stem have to decide. So for example, if it's a story, it's coming back to the first 2 minutes, you read once, you read twice, see the task, pick up the details. If the details is a 25-year-old man while lifting up something, heard a pop, came back. So I'm thinking of something like a disc prolapse, post-trauma, something like that. It won't be a straight gut exam. It would be like a, checking your straight leg rest test, like a reflexes neuro kind of test. So those details will tell me what my focus examination is. But what's important is you rush through everything else as quick as you can and get to your money. So again, in history presenting complaint is money. In examination, doing that focused examination is money. I'll come back and talk to you about the focused, the examination stuff on another day. Then history. So recapping, we have talked about 2 minutes outside. We've talked about the script coming in, doing it confidently and clearly. We talked about the history of presenting complaint a lot, having a structure, having a mnemonic, going through it, thinking about diagnosis ruling in or out depending on the answers they give, and then finally the history. Now history again should be quick. Depends on what kind of station it is. If it's like a very general, someone presented with fatigue, obviously there's not much you can ask about history presenting complaint. One of the ways I hack that is I usually say, look, there's a lot of things that can cause fatigue. Let me just run you through some questions. Have you been urinating a lot? So I'm thinking about diabetes, if there's any polyuria. Have you had any changes in your mood? So I'm thinking about depression. So that's one of the ways I kind of make my own history presenting complaint. If they're not giving me anything, just make it, and that's how I make it. That's a discussion for another day. But once you come to the history, then you do your stock standard, any past medical conditions, any surgeries, any hospitalizations, anything that runs in the family, any allergies, medications. The last thing I'll talk about here is just the history in general. So some of the things that we think about in history is past history. We think about, we have medical, medication history. We've got family history. We've got allergies. Sorry, I should have actually the way I like to structure it. I usually ask, do you have any other medical condition, anything that runs in your family, any medication, any allergies, and then you can do a systems if you haven't done a systems before, right? Let me know if I'm missing anything here, but that sounds like most of it. Oh yeah, social stuff. So how could I miss that? So again, classic, you gotta can't miss that. And your social has smoking, drinking, substance. I should actually put alcohol. And substance. Okay. So substance and then systems review. Okay, so it should be very quick and dirty. Just go in, any other medical conditions, were you ever hospitalized, anything in the family, any medication history, any allergies, social history, smoking, alcohol, any substance, systems review. Obviously, you can plug and play depending on the case in itself. What I mean by that is it's an old person with like a cardiovascular presentation, then with the past history, I'd so ask that, do you have any medical conditions? If they say no, just checking, do you have any blood pressure? Do you have any diabetes? Do you have any cholesterol problems? So a very relevant example. Don't give examples for the sake of giving examples. That's a big no-no, and it makes you sound stupid, but give good examples. Have you had any surgeries in the past, if it's relevant for the case? Is there any heart conditions that are in the family, if it's a cardiovascular kind of thing? If it's COPD, smoking, if it's an alcohol thing, if it's an asthma, then you think about hay fever and rashes. Whatever it is, don't give like just blind examples that do you have any medical conditions such as cancer, blah blah blah. If they had cancer, they'd tell you. So that just makes you sound very stupid. So don't do that. It's okay to give examples, but just give very relevant ones to that patient, to that case, to that age. Otherwise, just make it punchy. Do you have any medical conditions? Anything that runs in the family? Any medications you're on? Some people like to plug in anything over the counter, allergies, social history, who lives with you. Obviously, if it's a side kind of, you cover your social a lot, 50% complain, smoking, systems review. Again, very punchy, and then practice this a lot, and then get feedback. If someone says, oh, you didn't ask about social, you didn't ask about this, maybe next time you can increase the time during which you ask that question. Otherwise, you're done. And then that's pretty much the end of the station. You can do a bit of systems review. If you have a good speed, if you finish quickly, you can spend some time to think. If I finish a station early, I say, thank you for answering those questions. Give me a moment. I'm just trying to think what else I need to ask you. And then I usually don't stay quiet. What I do is I summarize it. So these are two kind of skills. What I say is, give me a moment. I just want to make sure I have not missed anything. And I'm just checking. Told me you've presented with, pain, bleeding, cough, this. Anything else that I missed? No. And then usually my brain, because I've summarized to myself, thinks of a question. Ask about this. If it's a PE, ask about travel. Ask about chest pain. Ask about, something like that. So I think I'll stop it there.